Pediatrics. Introduction. Respiratory care in small children is very different from that in adults. There are anatomical and physiological differences, which mean that additional criteria need to be used for assessment and treatment. The age of the child affects his ability to understand and cooperate with treatment. Fear of the unknown is even more acute in children than in adults. At all times, children should be handled with care and respect. They should be given information and explanation about their treatment appropriate to their age and understanding. It is always easier and more pleasant when a child is compliant with treatment. Cooperation can be obtained by persuasion or by distraction, for example, by games, television, cassette tapes, or reading books suited to child's age and interest. Rewards can also be given for good behavior or bravery, for example, balloons or stickers. Occasionally, children may refuse treatment either because they simply do not want it or perhaps due to fear. However, if treatment is deemed essential, it must be given after thorough and careful explanation. It is important to include parents, relatives, and carers as part of the care team. Parents should always have a full explanation of why treatment is required and how it is to be carried out. Parents are able to refuse physiotherapy treatment for their child, but this rarely occurs in practice. Parents of sick children, particularly mothers who have recently delivered an ill baby, are extremely vulnerable to stress and should at all times be handled with tact and understanding. Parental stress may be manifested in different ways. For example, hysteria, apparent lack of concern or anger. Some parents are so distressed that they are unable to stay with or visit their sick child and may need special help to express their feelings of fear and panic. Parents benefit from physiotherapist support when they are required to carry out physiotherapy treatment themselves at home. Fathers are frequently wary of participating in treatment and may need extra encouragement. When children and parents are intensely involved in treatment sessions, siblings may often feel left out. It is therefore important to include them in some way, perhaps even in helping with treatment. A child's awareness of the implications of illness and treatment develops as he grows older. Explanations which are suitable for younger children will need to be expanded as the child grows older and begins to understand how his body works. Teenagers, particularly, have a more sophisticated understanding and may be beginning to think about the future and the impact of illness on school and social life, as well as body image. It is important for them to develop responsibility for their treatment, although they may often object to being told what to do or to being treated like a child. The physiotherapist treating any child with acute or chronic respiratory problems must be aware of the psychological problems affecting the child and parents and adapt her approach accordingly. Development of the lungs. The development of the lung can be divided into four stages: embryonic period, 3 to 5 weeks, pseudo-glandular period, 6 to 16 weeks, canalicular period, week 70 to 24, alveolar sac period, week 24 to term. Embryonic period, week 3 to 5. The lung buds starts as an endodermal outgrowth of fetal foregut. The single tube thus formed soon branches into two, forming the major bronchi. By cell division, the process of growth continues until at the end of this period the major lung branches are formed. Pseudoglandular period, week 6 to 16. During this period, the airways grow by dichotomous branching, so that by week 16 all generations of the airway from trachea to terminal bronchioles, that is pre-echinus, are formed. During this period, the pulmonary circulation also develops. Cartilage and lymphatic formation occur and cilia appear week 10 onwards. Canalicular period, week 17 to 24. The respiratory bronchioles alveolar ducts and alveoli, that is the echinus, start to develop during this time simultaneously with the lung capillaries. The air-blood barrier first appears at week 19, and towards the end of this period, surfactant synthesis begins. Terminal sac period, week 24 to term. Development of the pulmonary circulation continues and the respiratory bronchioles subdivide to form air spaces. The air spaces are lined by two different types of cells, type 1 and type 2 pneumocytes. Type 1 pneumocytes flatten and elongate to cover the majority of the surface area of the saccular air spaces. Type 2 cells only occupy approximately 2% of the surface and are responsible for surfactant synthesis and storage. Surfactant is the phospholipid substance which stabilizes surface tension in the alveolus and prevents alveolar collapse on expiration. Small quantities of surfactant are present at weeks 23-24 of gestation, and the amount present gradually increases until there is a surge at about week 30. Birth itself and the onset of respiration stimulate and mature surfactant production. Towards the end of the terminal sac period, the air spaces have developed into primitive multilocular alveoli. After birth, alveoli increases in size and number. The average number of alveoli in the newborn is 150 million. By the age of 3 to 4, the adult number of 300 to 100 million alveoli has been reached, but alveolar growth continues until about 8 years of age. Anatomical and physiological differences between children and adults. There are several anatomical and physiological differences between children and adults that put children at increased risk of respiratory problems. Anatomical differences. Differences in upper airway anatomy allow infants to feed and breathe simultaneously up to approximately 3 to 4 months of age. It has been thought that this effectively makes them obligatory nose breathers so that any nasal blockage leads to apnea, though this concept has been questioned. During clinical observation, infants with nasal passages occluded either by mucus or tubes have been noted to have an increased work of breathing and spells of apnea. The lymphatic tissue, adenoids and tonsils may be enlarged in the infant. The tongue is also relatively large. These factors may contribute to upper airway obstruction. The smaller diameter airways of infants, particularly those born preterm, offer very high resistance to airflow, and any mucosal edema will significantly increase the work of breathing. Bronchial wall structure is different in infants. Cartilage is less firm and there are proportionately more mucous glands. Both these factors predispose to airway obstruction and collapse. There are fewer alveoli in young children and therefore less surface area for gaseous exchange. The collateral ventilatory channels between alveoli, respiratory bronchioles, and terminal bronchioles are poorly developed until 2 to 3 years of age, predisposing towards alveolar collapse. Infants' ribs are horizontally positioned, therefore there is no bucket handle movement of respiration. In addition, weak intercostal muscles mean that the infant is more reliant on the diaphragm for respiration. Adult rib configuration develops as a child adopts a more upright posture when gravity pulls the anterior ribs downwards. The horizontal angle of insertion of the diaphragm combined with the compliant cartilaginous rib cage of the infant means less efficient ventilation and distortion of chest wall shape on inspiration. The heart and other organs, example thymus, are relatively large in infants and therefore there is relatively less space for lung tissue. Normal chest radiograph. Physiological differences. The lungs of infants are less compliant than those of older children and adults, particularly in preterm infants less than 37 weeks gestation. there, where there may also be a lack of surfactant. Neonates, especially those born preterm, have irregular breathing patterns which may lead to apnea. Although short spells of apnea are considered normal, longer periods and those which require stimulation to restart breathing will need investigation. Anatomical differences in rib cage configuration do not allow the infant to increase lung volume to the same extent as an adult. Therefore, when in respiratory difficulties, the infant must increase respiratory rate rather than depth to maintain minute volume. Neonates may sleep for up to 20 hours a day, and 80% of this time may be in active rapid eye movement sleep compared with 20% in adults. During active sleep, there is a decrease in postural tone, causing a drop in functional residual capacity, thereby increasing the work of breathing. The diaphragm in the adult is comprised of approximately 50% of fatigue-resistant type 1 muscle fibers, whereas a neonate has only 25%, and preterm infants may have as little as 10%. Therefore, there is an increased susceptibility to fatigue of the diaphragm. Children have a higher resting metabolic rate with greater demand for oxygen. Any increase in demand can therefore cause hypoxia more rapidly than in adults. Hypoxia in infants causes bradycardia less than 100 beats per minute rather than tachycardia as in adults. Infants and children preferentially ventilate uppermost lung regions rather than dependent lung regions as in the adult. Although the pattern of perfusion is similar, this difference may persist as late as the second decade of life. In acutely ill children with unilateral lung disease, oxygenation may be optimized by placing the good lung uppermost. The small infant, the closing volume exceeds the functional residual capacity. In dependent regions, airway closure may occur even during normal tidal breathing. Respiratory assessment of the infant and child. Careful assessment is essential to identify a problem requiring physiotherapy intervention. Many aspects of assessment will be the same as in adults, but specific differences are listed below. Medical notes. Information can be extracted from the medical notes relating to present condition and past medical history, etc. When assessing a neonate, the following points are relevant. History of pregnancy, labor and delivery, the Apgar score, which relates to heart rate, respiratory effort, muscle tone, reflex irritability, and color, and gives an indication of the degree of asphyxiation suffered by the infant at birth, gestational age, and weight. Discussion with the relevant carers. Discussion with medical staff, nursing staff, and the parent carer is essential to obtain correct information about recent changes. Questions may include: how stable has a child's condition been over the last few hours? How well is handling tolerated? Does the infant become rapidly hypoxic or bradycardic? How long does he take to recover from the handling episode? Is the infant being fed? If so, is it via the oral, nasogastric, or intravenous route, and when was the last feed? Is the infant properly rested from the last handling episode? Observation charts. Important information can be gained from nursing charts. Pyrexia may indicate a possible respiratory infection. In preterm infants, a temperature of less than 36.5 degrees Celsius indicates that non-essential handling should be delayed until the infant's temperature has risen. The core to peripheral temperature gradient should also be noted, particularly in the critically ill patient. Tachycardia may be due to sepsis or shock. It may also be caused by inadequate levels of sedation or analgesia. In preterm infants, both self-limiting bradycardias and bradycardia requiring stimulation may be due to many causes, including retention of secretions. Apneic spells in the infant may indicate respiratory distress, sepsis, or presence of secretions in the upper or lower respiratory tract. The trend of arterial gases and their relationship to oxygen saturation and transcutaneous oxygen should be noted together with the degree and type of respiratory support. Results of investigation observations. Results of investigations and other relevant observations should be referred to as appropriate. Examination. Examination of the older child is similar to that of the adult. The following specific consideration should be made. Clinical signs. Clinical signs of respiratory distress are listed in box 13.1. Clinical signs of respiratory distress. Respiratory recession, intercostal, subcostal, sternal, nasal flaring, tachypnea, expiratory grunting, stridor, cyanosis, abnormal breath sounds. Cardiac, tachycardia or bradycardia, hypertension, hypotension or other general. Neck extension, head bobbing, pallor, reluctance to feed, irritability, restlessness, altered conscious level, headache. Recession occurs because of high negative pressure generated on inspiration, pulling on the soft, compliant chest wall and may be sternal, subcostal, or intercostal. Mild recession may be normal in preterm infants, but in older adults is a sign of increased respiratory effort. Nasal flaring is a dilatation of the nostrils by the dilators nares muscles and is a sign of respiratory distress in the infant. It may be a primitive response attempting to decrease airway resistance. Tachypnea, respiratory rate greater than 60 breaths per minute, may indicate respiratory distress in infants. Normal values are listed in 13.1 table. Grunting occurs when an infant expires against a partially closed glottis. It is an attempt to increase functional residual capacity and thereby improve ventilation. Stridor is heard when there is partial obstruction of upper trachea and or larynx. Obstruction may be due to collapse of the floppy tracheal wall, inflammation, or an inhaled foreign body. Cyanosis is an unreliable sign of respiratory distress in infants and young children as it depends on the relative amount and type of hemoglobin in the blood and the adequacy of the peripheral circulation. For the first 3 to 4 weeks of life, the newborn infant has an increased amount of fetal hemoglobin, which has a higher affinity for oxygen than adult hemoglobin. The result is a shift of the oxygen saturation curve to the left in an infant. Auscultation of the infant and young child may be difficult owing to the easy transmission of sounds. In the infant who is ventilated, referred sounds from the ventilator, including water in the expiratory tubing, make assessment difficult. It is often impossible to hear any breath sounds in the preterm infant who is breathing spontaneously. In the older child, secretions in the nose or throat may lead to referred sounds in both lung fields. Wheezing in the younger child or infant may be due to bronchospasm, but could also be due to retained secretions, partially occluding smaller airways. Cardiac manifestation of respiratory distress include an initial tachycardia and possible increase in systemic blood pressure. This changes with worsening hypoxia to bradycardia and hypotension. Neck extension in an infant with respiratory distress may represent an attempt to reduce airway resistance. Head bobbing occurs when infants attempt to use the sternocleidomastoid and the scalene muscles as accessory muscles of respiration. It is seen because the relatively weak neck extensors of infants are unable to stabilize the head. Pallor is commonly seen in infants with respiratory distress and may be a sign of hypoxemia or other problems including anemia. Reluctance to feed is often associated with respiratory distress, and infants may need to take frequent pauses from sucking when tachypnic. Alterations in conscious level should be noted. A reduction in activity may be due to neurological deficit or following the use of opiate analgesia, but can also be due to hypoxia and may be accompanied by an inability to feed or cry. Irritability and restlessness may also be indicative of hypoxic state. Other relevant observations: the behavior and manner of a child can give important clues about his respiratory state. A child who is sitting up and playing happily is not usually distressed, whereas one who is agitated or irritable may be showing signs of hypoxia. The child in severe respiratory distress may be withdrawn and lie completely still as if saving all his energy for respiration. It is important to note muscle tone and appearance in the infant or child with respiratory distress. A hypertonic child will have increased difficulty with breathing, coughing, and expectorating. Children with hypertonia will also have difficulty with clearing secretions. Abdominal distension can be a cause of respiratory distress in infants or can worsen an existing respiratory problem because the diaphragm, the main respiratory muscle in infants, is placed at a mechanical disadvantage.